Hello, everyone. Welcome to episode 113. These next two episodes were recorded during the recent Materialized 2026 conference in Leuven, Belgium, focusing on 3D planning and printing in hospitals. In this episode, I had the opportunity to interview Dr. Tristan Ramcharan, a consultant pediatric and sports cardiologist at Birmingham Children's Hospital. We discussed how he and his colleagues leveraged 3D printing for surgical planning, education, and patient communication for children with congenital heart disease. We also discussed related systemic challenges and the 2D versus 3D generational divide. Enjoy. Please listen to the disclaimer at the end of this podcast. Hi there, Tristan.
How are you doing?
Good. Nice to meet you at this conference.
Thank you. It's been really lovely being here, actually. Thank you.
And I appreciate this opportunity to allow me to interview you. Why don't you tell us about you, who you are, what you do on a daily basis?
Yeah, sure. So my name is Dr. Tristan Ramcharan. I'm a consultant pediatric and sport cardiologist in Birmingham Children's Hospital in England. So kind of my day-to-day job is mostly obviously pediatric cardiology. I look after young children from birth right up until 18. Most of that's congenital heart disease. Some of it's acquired and inherited. I also do sport cardiology. So I look after quite a lot of young athletes from around the UK, the patients who've had operations before, or children who've been picked up who are athletes in themselves, who've been picked up through screening to have heart conditions. So I look after those. And of course, my big role, or my kind of bread and butter, is imaging. So I do cardiac CT. And of course, through that, we do a lot of 3D reconstruction, 3D printing, and segmentation.
Yesterday, I had a glimpse of your work involving imaging and 3D technologies. Why don't you expand a little bit of what you use currently for your practice?
So we've been using 3D for probably about 3 years or so. We've got quite a nice program set up at Birmingham Hospital with a collaboration with Aston University. And we work through our students, our radiologists, our cardiologists, and our surgeons. We've basically been using 3D printing for three main reasons, really. The first is we use it for surgical planning and surgical training. So, for example, a child who's having an operation with quite complex congenital heart disease, and so the actual heart is quite difficult to understand, quite difficult to get your head around sometimes. And so we use the models to work out exactly, for example, where the hole might be, what the relationship between structures might be, so that when we actually have to go into theater, we have an understanding beforehand of exactly what we need to do. For example, if we have to print a patch or a baffle, that can help us to also plan the operation. And we've been doing that for more or less 3 years or so. Over the past 12 months or so, we've been using 3D segmentation more for teaching and for helping our trainees, our students understand congenital heart disease in a lot more detail. We use it, for example, one of the challenges that we have with congenital heart disease, because it's so difficult to get your head around sometimes in a three-dimensional aspect. We obviously have post-mortem specimens or morphology specimens, which are a very finite resource. And there's not many centers in the UK or the world, for that matter, that have access to that laboratory and have access to those specimens. And so although we can demonstrate on them, we don't really let our students or trainees touch them, because obviously they will degrade over time. And so it is a very finite resource. And so what we do instead now is if we've got a three-dimensional segmentation done, we can print that, and we can print it over and over again. So if, for example, the model breaks or gets degraded over time, we can just print another one. Of course, there's a cost behind that, sure.
Yeah.
But in terms of a specimen that's been there for 30 or 40 years, this is obviously a much better way of doing something in a reusable fashion, and in a way that's actually cost-effective as well.
Yeah.
And probably most recently, and for me, I think probably the biggest difference that this program can make is in terms of explaining conditions to families, so family education. We've had a most recent example where we've been working with the BBC to speak to a family and go through a case study. And I think for me, there's two ways to look at that. We have conditions sometimes where, with the best will in the world, no matter how much we would like to make a difference or to do something, the heart's too complicated, too much of the heart's missing or malformed, and we really can't do an operation. And these kids sometimes can look very well, but in reality, they are struggling. And that palliative care approach, where we really can't do anything, and the child, unfortunately, there's no operation we can do to help the child. I think having a three-dimensional model can help in that situation, because you can really explain to the family what the problem is. And they can see for themselves why it's so difficult for us to do something and why, no matter what we wish we could, we really can't help here. And so I think that's really important. And on the converse, we have patients who, for example, in the article I shared, where they look so well. And as a parent, it's so hard for you to understand or get your head around, well, my child looks completely fine. How is it that she can have, or he or she can have such a serious heart condition? And actually, by printing that model or even virtual reality, we can then show them exactly what the problem is,
Hmm.
where the hole is, what the communication to their structures are, and why, without an operation, in the long term, this will be a problem. And for me, I think that's the most beneficial way because that really helps our families to understand in a lot more detail exactly what we're doing and exactly what the condition looks like.
Yeah, I went to medical school way before you, 20 years ago. I don't even have that access to 3D images. We did not have any virtual
Yes.
surgical planning that's widely accessible. We use cadaver, which is extremely expensive to both purchase and also maintain.
Yeah.
So that is an evolution, I would say, for the field. Now, you mentioned that you're an imager. What do you think the role imaging played in this whole evolution of 3D technology?
Yeah, it's a fascinating question. Imaging started off for us with echocardiography.
Hmm.
And echocardiography initially was what we call M mode, where basically you had a black and white image, and it was just basically
That's a two-dimensional.
exactly, yeah, two-dimensional black and white image where it was just a moving structure, and that's all you understood. And to be fair to my predecessors, they were able to use that to make complete sense of things, which I look at it now and think I wouldn't know where to start. And I think that's a generational aspect as well. And actually now we have echocardiography, which is two-dimensional and three-dimensional. We have cross-sectional imaging, which is either cardiac CT or cardiac MRI, and of course cardiac catheterization and angiography as well. And we can use all these modalities and put them together. But at the end of the day, they're mostly all two-dimensional aspects. And so being able to bring the three-dimensional aspect from the same data set, the imaging data set, we can then pull that in and we can show exactly what it looks like in a three-dimensional way. So actually, it's really transformed how imaging is because now you can just see for yourself with a fairly minimal amount of work how much better and how much easier it is to understand. And that relationship is just it's transformative, I would say.
Yeah, and I'm still thinking about this whole 2D to 3D translation even now, as we have already had a conversation about it, is, yesterday during the conversation, people were mostly want to transfer the 2D images to 3D. But then there's some slides showing that they also show orthogonal 2Ds to translate 3D back to 2D. What do you think of which trend are we eventually going to get to?
Yeah, I think we'll probably be somewhere in between is the honest answer. I think for those of us who've been doing this specialty for a long time, we still like our 2D data sets because that's what we are so accustomed to seeing. Our newer trainees, they are exposed to both in probably equal distribution, I would say.
Mhm.
And so they would probably be comfortable with both. Whereas I think for someone for a different generation, I think
Yeah.
you still need that base data because that's what you've been you've grown up on or been training on for 20 or 30 years.
Chest x-rays, on chest
Exactly.
x-rays.
Well, exactly, right? And so I think that's still so important. And even for myself, who's kind of gone from 2D and 3D over the past 20 years, I still really need to see that two-dimensional data set because I can build that three-dimensional data set in my head, but I still like that two-dimensional picture. And also explain it to somebody else. It's some ways it's much easier to explain a two-dimensional picture rather than a three-dimensional picture because it just takes a bit more effort and thinking sometimes to explain the three-dimensional side of things.
Yeah, we're different generations of physicians. I mean, I'm not that old. I don't feel old, but we're definitely trained in a different technological environment. Do you feel the fact that there is a huge generational change matters in terms of how you communicate to patients with these tools?
Yeah, I mean, I take the example of one of our medical students now who's been doing a lot of work with us. And he builds models himself. He has his own printer, and he just creates things out of nowhere. And I look at him and I think, you're not even that much younger than me, and you can just do all these things. And I think about my kids and what they can do, and I think, where will they be in 10 years' time?
Hmm.
And actually, what they will need to train and to teach on. And actually, yeah, I think it's so different, isn't it?
Did you grow up playing video games?
Yeah, I mean, so I was never good at console-based games. I was very good at PC games actually, but I was never very good at getting consoles good working. And so I still don't, even now I don't have that. But PC games were for me phenomenal actually. But the kids, they just do everything, right?
Right. I mean, they're a digital native.
Yes, exactly. Well, is it, almost a Netflix generation. They struggle with ads. We grew up with watching a program, and there would be 5 or 10 minutes of ads between every session, and you just accepted that. Now my kids want to know where the skip ad button is when we watch terrestrial TV, and I'm like, no, you have to watch the ad. There's no choice. They can't understand why.
The trade-offs in life.
Exactly. Well, exactly.
So we're both in the Materialized conference, and the focus is 3D planning, 3D printing at the point of care. What's your biggest takeaway so far, and anything that's pleasantly surprised you or something just surprising for you that you feel like we should talk about?
I think for me, obviously, we are very tunnel vision. And so we see what we do on a daily basis, and we almost forget sometimes there are other specialties out there. There are other um, aspects to three-dimensional or segmentation. Actually, it's been quite nice to see the other uses of segmentation, even biomedical and non-biomedical. And I think it's nice for us to think about, because I've always wondered, or always hoping next, where can we go next from here? Obviously, we're very good at congenital heart disease, but within our own hospital, who else can we involve? We've involved urology to an extent a little bit, but what about neurosurgery? What about max fax? And actually, it's been quite nice to see what others are doing, to be able to think, oh, actually, I can bring that into my field actually now.
And at your hospital, you're in cardiology. Does the other specialties also use 3D technologies as well?
So at the moment, not really, and I think
Okay.
that's something we can work on now. I think everyone's very busy, and it's something that's obviously been a transformative effect to us. But in terms of other pediatric specialties, it's not really been that much, even around the UK. And so actually, I think if you can bring it in now and say, I can demonstrate and said, well, actually, in Barcelona, they're using it for this and that and this other specialty. Actually, what about you? What do you think? Can you guys help work with this, and can it help you? And I think that's something where we can move on in the next 12 months or so. I think that will make a big difference to our hospital as a whole.
Well, at this conference, I heard this word reimbursement multiple times, and I think it is a very important key factor to think about. The resources are scarce, especially given the recent NHS, I would say, dramas that's going on, probably ongoing, and the underfunding. How do you deal with this?
Yeah, it is a challenge. Funding is not easy, of course. And when there's a centralized funding model, and obviously everyone has to get a piece of that pie, it's very difficult to then come up with something new and transformative, which of course costs money, and there's a
Yeah.
financial aspect to it, and often is not very cheap. And so we were very lucky to have charity funding. So our Birmingham Children's Hospital charity were fantastic, and they gave us a grant of £150,000 for over 3 years. And that really helped us to set the program up, to get the software in, to get the hardware in, and also to be able to pay for the models that we print. And I think that's why we're very, very grateful to them. And of course, we are hoping that they will continue to support us, because I think at the moment there isn't enough acceptance of this technology in the NHS just yet to say that actually this is a standard of care and it should be centrally funded. So I think for now we will have to keep asking for charity funding, and it's been really helpful actually, to be fair to them, that they've really been very supportive to us.
So I saw a picture of you with the Queen on LinkedIn. Obviously, the royal family is involved, I hope. But beyond the royal charity source, do you have? Are you looking anywhere else to look for this funding?
So I think we're staying locally for now, because I think, eventually, hopefully, as a health system, as a country, we can come together and work together across different centers. But I think for now, where people are still doing slightly different things themselves, I think we'll probably stay central and stay local to our charity, and rely on their support for now.
Well, nonetheless, I'm going to post a link of your donation,
Thank you.
if you have one,
Yes.
on our website. So
Thank
if people want to donate, they can do that. Now, finally, do you have anything to say for the next generation of doctors, probably in their kindergarten at the moment? Uh, what do you have to say for them?
I mean, I think medicine is one of those fields where once you're in it, you understand how rewarding it is. You can see the difference it makes on a daily basis. I think for me, particularly working with children every day, and parents, so I see both sides. I see the difference it makes to a newborn baby,
Mhm.
teenager, an athlete for that matter. But I also see, as parents, the emotional struggle that they go through, and coming from one side to the other, going through the operation, the just anxiety on their faces to come out, just that sheer relief and reassurance and just gratitude that they have. And so I think that's something that I'm sure you get in other fields, but I think it's unlike anything else in medicine. And so I think for me, it's an amazing field to be in medicine. I think there's no doubt that it has challenges, but as a rewarding career, I think there's nothing like it.
Yeah, some of the conversations you have to have are really difficult that I, as a radiologist, do not have to go through. And so I thank you for having those conversations and also provide excellent care for the patients. So thank you so much, Tristan, for joining me today. Hope to see you another time.
Absolutely. Thank you so much for having us.
This podcast is for educational and informational purposes only. The views expressed do not constitute medical or financial advice. The technologies and procedures discussed may not be commercially available or suitable for every case. Always consult with a licensed professional.